Okay, good morning. This is episode 12. When is it about the patient? And I'm Christine McMahon. I'm here with my co-host Carrie Burmeister, and today we have Dr. Annette Collier with us, and we're going to talk about palliative care. So our first question is, I guess, what is the definition of palliative care, Dr. Collier?
Yeah, good morning. So our definition of palliative care is that it is a medical specialty. It's a relatively new medical specialty, being a separate, kind of considered separate specialty since about 2008. But our focus is on those patients and their families who are dealing with a serious illness. Something unique about palliative care is that it is always interdisciplinary. And by that, I mean that I, by myself, as a physician, cannot offer a full palliative care service because palliative care addresses suffering and the suffering that's associated with a serious illness. Suffering comes from physical sources, emotional, existential, faith-based suffering. So my team is not only clinicians, physicians, nurse practitioners, but we have chaplain, we have social workers, we have RNs that answer questions in the office to make sure that we can address suffering. So back to the definition, it's a medical specialty. We help and care for seriously ill patients. I mentioned families because we also care for the caregivers, not directly necessarily, but we realize the high burden that living with a serious illness carries. And so we also speak to include the caregiver, the families in discussions and offer them areas or sources of support. And our focus, the seriously ill patients usually are seeing many specialties. We focus on quality of life, and to have a good quality of life when you're dealing with a serious illness, it really means that your symptoms have to be well controlled. So many people think of palliative care as a symptom control service, and that for sure, pain and nausea, depression, anxiety, constipation. But the other part of living well is making sure that your wishes are followed, that you have an opportunity to express what is important to you. So we make sure that we have those deep conversations with patients.
Is there a difference between palliative care and hospice care?
There is, and that's where a lot of misconception, but really, in some ways, we are more alike than we are different.
Okay.
Most of the things that I said about palliative care, and maybe all of them, it's interdisciplinary. Hospice is interdisciplinary. They focus on suffering. The patients are seriously ill. However, hospice is a type of palliative care, but hospice is reserved and is appropriate when patients have reached the stage in their illness that they no longer want to pursue life prolonging treatments or aggressive treatments, or those types of treatments are no longer available to them. They've had, for example, cancer, we think of a lot. For example, they've had all the treatments they can for cancer, and maybe they've had palliative care through those stages, but now there are no further treatments to fight the disease. But there still are a lot of things that hospice can do for that patient. So hospice is reserved for the terminally ill. Their disease has advanced to the point that the physicians certify. And in the United States, it's a little different because our hospice qualifications is really defined by the hospice Medicare benefit, meaning you have to have a life expectancy of 6 months or less, and you have to forego life prolonging measures. So the physician certifies that, and then the patient qualifies for a wide array, really the hospice Medicare benefit, and I say Medicare, most private insurances really mirror what Medicare has done for their hospice benefit. It's just a very comprehensive service, but again, reserved for those patients who are terminally ill, estimated to be in their last 6 months of life, and are foregoing, no longer pursuing life prolonging treatments.
I have a
So-
kind of a stupid question, just if you don't mind. Have you, in your experience, ever seen anybody turn around and leave hospice?
Definitely.
Really?
Yeah, I met a patient yesterday that was one of those that when a patient enters hospice, we encourage patients to, if they appear to be terminal, if their disease has progressed, they're so ill that they could die within 6 months, and their goals, meaning they want the type of care that hospice focuses on, we bring them on. Sometimes patients get better. That usually doesn't happen in cases of terminal cancer because it's, pretty predictably progressive. But the most common, I guess I can think of, is a patient with advanced dementia. They're declining, they're losing weight. Maybe they've gotten a pneumonia and it looks like their condition is really going down. We encourage, okay, get hospice services so you have all the support. Well, some patients kind of bounce back, and the hospice will cover and follow them for usually a few months. But if they go back towards their baseline, they no longer look like they are going to likely die in 6 months. So we have to have that tough conversation that it's time to graduate, time to graduate from hospice. And it is a tough conversation, believe it or not, because hospice gives such good comprehensive care. And when that's the kind of care that people want, when they learn that they're not going to have their hospice team anymore, it can be good news, bad news.
Well, and you're probably providing a respite for the family members too.
Yeah.
Mhm.
Yeah. Just having that, hospice, it doesn't give 24-hour or daily care, but they are a phone call away. And that type of comfort really is a beneficial to the caregivers.
So let me ask, Chris, let me jump in real quick.
Okay.
So you mentioned that hospice is more end of life. And non-prolonging life measures are no longer in place. So with that palliative care, could you have palliative care as well as be going through cancer treatment? I mean, are you doing both sometimes and still receiving treatments? I just want to make sure I understood.
Definitely. Your patients, most of our patients are aggressively sometimes pursuing life, prolonging treatments, whether it be cancer treatments, whether it be end stage heart disease, and their goal is still to receive any life prolonging measures, being in the hospital, sometimes even having advanced treatments like heart assist devices.
Okay.
Our role in that is helping them deal with any symptoms, the life-changing events because they're dealing with a serious illness. But definitely most of our patients are still pursuing life-prolonging treatment.
So that kind of segues us to the most people attributed palliative care to the dying, but that's not necessarily correct because it's not just for people who are dying.
Right, right. Do many of our patients have diseases that eventually progress and they might qualify for hospice? Yes. Not all, but many do. We have many people that graduate from palliative care. Maybe they're going through a treatment and their treatment is over, or for one reason or another, they're just symptoms are well controlled. They're dealing with their serious illness, coping well, and they don't need our support maybe anymore at that time. But yeah, most of our patients are not terminal. That being said, Some patients who are on palliative care are doing treatments even as they're getting weaker. And because they want, that last available treatment, it's important to them to be in the hospital and live as many days as they can. We align, we support that. If that's your wish, then we will walk that journey with you with palliative care. You can't qualify for hospice because you want these life prolonging treatments, but our focus is making sure we know what their wishes are and supporting that.
What are some of the most common diseases you see palliative care used for?
Cancer is probably still the most common. It was the disease category that I think palliative care really took off on, so to speak, but probably about half of our patients are cancer patients. The other common medical conditions would be lung disease, pulmonary fibrosis, emphysema, COPD, heart disease, advanced heart failure, neurologic diseases, Parkinson's disease, dementia, patients with kidney disease, especially end stage, a patient that's on dialysis sometimes suffers a lot of symptoms and stress. Liver disease, patients with cirrhosis also can benefit from palliative care services.
So with palliative care, is that only administered in hospitals or other medical facilities?
It's not. We like to say that we will be where the patients are. So I practice primarily in the hospital setting right now. However, our team also sees patients in several clinics throughout the area. So the outpatient setting is where probably most palliative care happens. And in a clinic setting, sometimes those clinics are independent. Sometimes they're embedded in an oncology clinic. If a patient becomes very frail and it's impossible for them to get to a clinic setting, there's availability of doing home visits also.
Oh, okay. When should palliative care begin? What stage of the disease should the patient speak to someone to start palliative care, or the patient's family?
Sometimes we say it's never too early for palliative care. And as soon as a patient or family member is realizing that there is suffering going on, there are symptoms that aren't controlled, there is just the stress of the illness, that they need some extra support, it's time to at least call palliative care, have a conversation with, the palliative care office and see what services would be helpful. There are, in the literature, there are some recommendations in the oncology field. Studies about 15 years ago demonstrated the benefit of early palliative care in patients who are diagnosed with advanced lung cancer, meaning lung cancer that has spread to other areas. This study showed that there was a slight prolongation of life, less pain, less suffering, less chemo at the end of life, if palliative care got involved within the first 6 weeks of an advanced cancer diagnosis. So very early, those patients are going on to get treatment, but ready at diagnosis, it's realized that this patient is not curable. And the treatments are sometimes burdensome. They can be very beneficial, but they are burdensome too. So I think people wait too long to call for palliative care. Probably because the word brings up thoughts of, you mentioned thoughts of death, thoughts of we're not going to continue to fight your disease. maybe a lot of people just don't realize that there's a service, there's a specialty that helps them deal with the difficulties of serious illness too.
Just from personal experience, my mom died a couple years ago from breast cancer. And so this is very interesting to me because one, I think we waited too long. She was only in hospice a couple days before she passed, but she had like constant UTIs or what felt like UTIs, which may have been dehydration. We don't know. But and she was going back to the family doctor. I feel like that family doctor at that point should have been seeing the frequency and maybe suggesting something like palliative care, because I think sometimes you don't know what you don't know when you're in the thick of trying to care for a loved one and, you know, trying to keep them home where they want to, where they feel good, feel safe, and as they're going through a difficult time battling a disease or whatever. But is there a relationship that needs to be developed more with some of either the specialists or the primary care to get them to refer this, you know, for people just like me and my sisters, we didn't know to reach out to palliative. All we had heard of was hospice, and at that point, you know, she was still receiving treatment and didn't want to jump into hospice. I think, you know, it was, like you said, people thinking of end of life then and not fighting that any longer.
Yeah, sorry to hear that, Carrie. Patients and families can call themselves to a palliative care service. Sometimes I think the public is getting more educated on palliative care than sometimes medical people, you know.
Oh,
and, you know, it kind of is the ripple effect. You know, if a person has a great experience with palliative care, then when they have another family member or see a friend suffering, they make that advice and, you know, tell their story and make recommendations. So it really spreads that way. When we get a referral from a family or a patient themselves, we always reach out to the primary care or the other main medical doctor, whether it be oncology or the heart doctor or the lung doctor, to pull them into the conversation, meaning send them notes. But you don't need permission from them to get palliative care.
Oh, that's good to know.
So you don't need a referral.
Don't need a referral.
Well, I'm just thinking that those are probably hard conversations. If you're a family member, that when it's time to make that decision. So just like with Carrie's example, your mom's home, I don't know what her mother's state of mind was. Many times people in those situations are in a little bit of denial and they're not ready to accept that we're nearing the end here. And so if you're Carrie and you have to have that conversation with, well, Mom, I think it's time that we call palliative care. If the parent has any denial, they're going to say, you're not a doctor.
Mm-hmm.
You know, why would you say that? Why? I'm fine here. So I could see those being some tough conversations for people in those situations.
Well, and I can tell you in our experience, we didn't even understand what palliative care was. So we only thought hospice. And so I'm super grateful for this podcast and to be learning and hopefully educating others, because obviously we did wait too long to get the help she needed. And of course that weighed on my dad, who was her primary caregiver during that time too, you know, for him to try to take care of her when, you know, and more frequent trips to the ER than probably necessarily had to be because we weren't aware. So I'm really grateful for the knowledge you're sharing on this. So
you're welcome. You know, to your point about difficult conversations, as I'm listening to that, I'm thinking sometimes we use a different word, not to be untruthful, but suggesting to our loved ones, if you're the caregiver and want to call, or if I'm a physician wanting my patient to get an extra service, describe it as supportive care. We have this service that helps you with your symptoms, helps you with the stress. It's a support service. And describe what palliative care does before using the word palliative care, if that makes sense. And once a family realizes, where a patient realizes what the service is, what we are doing for them, we can call ourselves anything. Palliative care isn't scary anymore when they initially, or once they know what we're doing. The other angle, if I can refer to it as that, if the loved one, the patient is resistant, but the caregiver is feeling a lot of burden and a lot of need, our loved ones do a lot for us. And I've had some family members go to their mother or their father and say, Mom, I need this. I need some extra support to take care of you well. Can we get this service so I can help? So I get some support taking care of you. And that usually opens hearts to, they want to make the burden on their family as light as possible. And it's all true. Palliative care is coming in to make the care burden lighter.
Well, I think it's sometimes, I've never been in the position of dying, but I've been in the position of the caregiver. I think that in some ways it's harder on the family than it is on the person who's ill, just because you're still trying to kind of have your normal life, and then you have to take care of this person, and you have all this additional responsibility. And if you see it for what it is, if the person is in denial, it's very difficult. I told my own mother that she was not getting better, and because she was in denial. And I said, you are not getting better. I talked with your doctor, we're at the end here. But she just thought I didn't know what I was talking about.
It'd be nice to help with that conversation.
It's very hard. My voice was shaken, it was a very hard conversation.
Caregiving is extremely difficult. And, in palliative care takeaway, it continues to be, a very difficult job. Sometimes we'll go into homes and just realizing, there's some equipment that you could get, to help care for your loved one. There are some extra services that might help you do this. We're just talking about it. So some really concrete ideas of how to make that job or that commitment a little bit easier.
So we've kind of covered the next one as far as who initiates palliative care. So it can really be anybody, since it does not need a referral. I guess I always thought it needed a referral from like the specialist or family medicine.
In the hospital setting, in the hospital setting, we see patients only upon referral. So that is the one setting that I guess if a patient's family wants to be seen by palliative care, they could make the request, but it always goes through the attending physician in the hospital setting.
Are there any insurance barriers? Do you ever see that come up for getting patient palliative care?
There are, I'm not knowledgeable about all the different insurances, but I know that our billing office or financial office does screen for, what patient's insurance covers as far as palliative care. And there is a difference between, Medicare has good coverage, but there is some differences. A patient would have to call their own insurance company to see what it's billed. Palliative care is billed like any other physician or medical service.
Okay.
And some insurances have, I guess, preferred providers, and that might be a hoop to jump through.
Gotcha. How is it? Has palliative changed in the last 10 to 15 years? It feels like a newer specialty to me, being in healthcare for over 30 years. So I don't know if it feels like maybe it's a newer specialty, but maybe it's existed all along and I just wasn't aware. Obviously, I wasn't even really understanding it a couple of years ago. So
You are not alone, Carrie. You are not alone. As I reflect on that, I started in palliative care about 15 years ago. So, and it was a very new specialty then. As it's a specialty that clinicians can become board certified in now. There's a fellowship, there's extra formal training that and tests to take so that you're board certified. That just started, like I mentioned, in about 2008. So compared to other medical specialties, we are still maybe not infancy, but still adolescents for sure. And so the changes, I think we've gotten from an academic side, there's more studies, there's more research going on in palliative care. I wish that knowledge would have grown more in 15 years than it did, but it's growing. So there is some growth and appreciation, and the physicians that are in training now get an exposure to palliative care, and especially in the hospital setting, I think they're going to come out of their training with even greater appreciation of what palliative care can do for their patients. At least that's my hope, that as they go on to different specialties, they'll remember the basics of palliative care. There are some specialties that have embraced it more than others, but I think the practice itself, palliative care, hasn't changed. Our focus has been the same since inception, but we are getting footholds, in having other people understand so that we can get referrals or get to see patients and help them earlier.
I think so many people just associate palliative care with hospice, and that you only get palliative care when you're at hospice and you're going to die.
Yeah. And the wording is unfortunate, the wording that is an overlap term, so to speak. And maybe if, we were to do this all over a couple decades ago, but the word is very descriptive, to palliate, to cloak, to take care of. So most of me loves the word, but I do realize that the misconceptions, which come with the fear of dying, doesn't it? I mean, just our society has such a fear of avoiding anything that might remotely be associated with the possibility that I might die from this. So that kind of ties into why the reluctance is not given away more.
Well, it's accepting your mortality, and most people struggle with that. When at the end of the day, the reality is we're all living to die. It's true.
One day closer.
We're just helping each other along the journey.
Well, right. Some people's journey might be longer than others, but at the end of the day, nobody's going to live forever. And if you accept that, I don't know. I think it's helpful to be more accepting of that. And I think as people get more educated, palliative care and hospice, that it'll get better. I know a lot of people don't understand it. And I, for one, associated it with hospice. So, as people learn and realize that, it's really just medical care that provides comfort of symptoms and emotional support.
Mhm, mhm. As I was listening to you mention that difficulty facing death, Justine, it made me realize that some people I meet and talk about palliative care and how we not only do symptom management, but help patients sort through their goals, their preferences. Sometimes medicine doesn't do a great job pausing, giving a patient the options, and sorting out which of those options best fits with that particular patient's values, preferences. They need, we all die, but many times we have some choices about how those last days, weeks, months. Sometimes we don't, but sometimes we do. And giving a patient some choice as to how that looks. When is treatment too burden? When is treatment it really aligns? Having those conversations is part of my job that I just love, because it just gives the control back to the patient and helps them realize that they have choices in making that the end of life as beautiful and meaningful as we can.
That's a good way to put it.
Yeah, excellent. Is there anything else that you think like the average person should know about palliative care? We've kind of really covered it, just understanding the difference between palliative care and hospice. But is there anything else that comes to mind that you really wish people understood about palliative care?
Yeah, I agree that we've really talked about getting the word out, and if there's any suspicion that palliative care may be able to help you, talk to your primary care, talk to your specialist, or call a palliative care office and just try to sort that out. And as we mentioned before, caregiving is tough. Being seriously ill is really tough.
Mm-hmm.
And I'm glad we kind of ended on the thought that you have choice, and we want to give the patients the knowledge, make sure that they know about their disease so that they have choices and how they deal with their serious illness, whether they're right at end of life or whether they're upstream. They have choices on how they live their life.
That's nice.
Good to know. Thank you so much for educating us on this today, Dr. Collier. We really appreciate your time. This has been really beneficial. I've learned a lot. I'm sure Carrie has too.
Yes.
So we do appreciate you educating us on palliative care, and hopefully we can help educate others.
Yeah, well, thank you. Thanks for helping to get the word out.
Okay, that being said, we'll close.